right, we are live right now. Um, I wanted to start off today by just saying Assalamu alaikum and welcome to uh, everyone, all the viewers that are joining us today on a Sunday afternoon um, from Canada as well as from other places, if there are anyone joining us from abroad. My name is Majid Hussain. I'm with the Muslim Medical Association of Canada as a treasurer. And this community health series is really something that we started at the MMAC to be able to give an opportunity for our communities to learn about medical issues. And this is not a very medical talk. It's basically for the community, and we hope that you guys enjoy it. So, without further ado, I want to start off by introducing our distinguished guest here today. Today with me, I have the privilege of introducing Dr. Adil Sheikh. Dr. Adil Sheikh is a specialist in urology. He completed his training at McMaster University in Hamilton, Ontario, and also at the University of Toronto. He treats all sorts of urological related conditions and has a subspecialty in laparoscopic and minimal invasive urological surgery. In particular, he has extensive experience with minimal invasive kidney and adrenal surgeries. He also initiated laparoscopic prostate surgeries. He's currently an adjunct professor at McMaster University with the Division of Urology and has a keen interest in educating students, his patients, and the community at large. So, please help me welcome Dr. Adil Sheikh. Thank you so much, Dr. Sheikh, for being here today and taking time out of your busy schedule to join us.
Assalamu alaikum. No problems. It's my honor. I'm glad to be here. I think this is a great initiative. And, for a second there with the countdown, I thought we were going to head into a geo news segment, but I'm glad I'm in the right place. Thanks for setting this up, and it's my honor to be here.
It's an honor to have you. I also wanted to make a shout out. This is near the end of November. It's the end of Men's Health Month, and this segment is really dedicated. It's a second part series to our Men's Health community education series. So we want to try and finish it off with a bang. I've been actually particularly quite excited about this talk. It will be different than our previous part one, and let's get started without further ado. So, Dr. Sheikh, myself being a family doctor, we see people come into our clinic all the time, with all sorts of problems. But men, we often find that they'll sometimes wait a little bit longer, especially middle-aged men, to come into the clinic to see us and to ask for help. I want to start off the first topic with something that is bigger than COVID, right? Like that's what's on everyone's mind these days, and that's always been around, and that's cancer. And something that men deal with is prostate cancer. And I wanted you to start us off by just telling us a little bit about maybe the age in which people can start worrying about prostate cancer, and the risk factors that may be associated with something that is so devastating. And then I think we'll just start there.
Sure, yeah. So, prostate cancer definitely is something that is very prevalent. The latest data would suggest that 1 in 7 Canadian men at some point in their life will experience prostate cancer. So it's definitely a prevalent condition. It's something that I think is vital to be, aware of. And for us as men, our fathers, our brothers, to educate each other on that and to sort of promote awareness about it. Prostate cancer is something that there's a very common adage that if you live long enough, you'll get prostate cancer. And so one of the, main risk factors is going to be age. Above the age of 50 is generally when we say that men should start, considering getting checked for prostate cancer. And if they have other risk factors for prostate cancer, then they should potentially even get checked sooner. The general consensus would be, start getting checked at the age of 40 or 45. The risk factors that would increase your likelihood for developing prostate cancer is going to be Black race. So patients that are of Black race, of African ancestry, they have a significantly higher risk for prostate cancer. And then the other one that's probably a little bit more obvious is family history. In particular, we're going to be a little bit more concerned about somebody that has a first-degree relative. So first-degree relative means like your father or your brothers. If they've had prostate cancer, then that's something that definitely you want to be aware of, and something that you want to screen for earlier. There's also something to be said about second degree and more distant relatives, your grandfather or, your cousins and such, but it's really that first degree relative risk is higher in that population. There's other risks that people will sort of consider or talk about, obesity, sometimes dietary things like, increased red meat and things like that. But those risks actually haven't been very well established. I think that that's a little bit of a misconception. And so, yes, the main ones are going to be age, race, and family history.
Thank you. So, I think the next thing that comes from that is, these are risk factors, some that people can change, and that means maybe their diet, maybe their exercise, and some that they can't. Family history, there's not really much you can do about that.
Mm-hmm.
Tell us this, when people, they get screened for these things and we talk about risk factors, how does someone know what kind of symptoms or even signs would someone have if they could be experiencing things to do with prostate cancer specifically? Like, how does someone know? And I'll just start you off by telling you that, I had a patient I remember came in his late 50s, and he really, and I won't get into details, but he had no idea. And later on we found out, but he came in for something that was unrelated, and then just the workup. So what kind of things do people experience, I guess, and what kind of tests should be done?
I'm really glad that you brought that up. I think that's one of probably the biggest misconceptions and one of the tragic sort of scenarios that we encounter as urologists. This lack of awareness of prostate cancer. A lot of men have this concept, and even, patients in general, men and women, but that, well, if I feel fine, if I'm not feeling anything, then I probably don't have cancer. It's very unlikely that I have cancer because I don't feel anything. So with prostate cancer, the symptoms, I tell my patients this, the symptoms are a very poor indicator of anything. And the reasons are twofold. One, when you have prostate cancer in the early and manageable stages, there generally are no symptoms at all. It's more so in the advanced cases, where they become locally advanced or metastatic, which means they spread throughout their whole body. That's when the cancer becomes manifest clinically, so with symptoms. And then the corollary of that is that patients that have symptoms, urinary symptoms, a lot of the times they'll mistakenly attribute these symptoms to cancer. But the vast majority of time, these symptoms are going to be attributable to non-cancer related conditions. So, an enlarging prostate is very prevalent in a benign condition, prostatitis, urinary tract infections, etc. So not only do the lack of symptoms not clear you from the possibility of having cancer, but also the presence of symptoms should not alert you to the fact that you might have cancer, because it's much less likely to be related to the cancer. So as I said then in the beginning, is that the symptoms don't correlate very well. And this is why, prostate cancer screening is so important. We have to sort of go and look for it. We have to rely on, speaking to your physician, getting tests potentially done, getting a physical examination done in order to safely and adequately, rule out prostate cancer.
Thank you. That's it's so interesting to hear that, because most times when people think of cancer, you think, yeah, I don't feel good. And in this, you're basically saying that you may have symptoms and very well not have cancer. And that happens quite often. And And oftentimes when you do have prostate cancer specifically and you are symptomatic, it may be quite late. And that's alarming. So that begs the next question, right? And what do men do? Like here I am, I'll lay it out there, mid-40s, and I don't have a family history. And what can I do, or what can I tell my fellow brothers to do in terms of going to see my doctor? Nobody wants I don't know if it's old-fashioned test, or everyone would rather go for a blood test. Nobody wants let's just say it, like a digital rectal examination to be able to look for things to do with the prostate. It's not comfortable. And so, what do they ask their doctor? What do they do? And then, of course, some people will be seeing you. What happens next? And when you talk about screening, what does that screening consist of, and how does it work?
So I think actually first, just to go back to one of the points that you made earlier, a lot of these risk factors are not modifiable. So what can men do in general as a preventative strategy? And, although there's nothing that's well established in terms of prostate cancer, modifiable things that you could do to prevent specifically prostate cancer, there's a lot of things, a lot of evidence, well-established evidence for cancer in general, all types of cancer. So specifically, I tell my patients, look, having a healthy diet, although it seems so cliche, but a healthy diet and regular exercise. These things are well established in the literature in terms of reducing overall cancer risk. So not specifically prostate cancer, perhaps, but all cancers. And, what does it mean to have a healthy diet? So, certainly minimizing the amount of processed foods that we eat, minimizing the amount of refined sugars in our diet. These are important from a dietary perspective. And then, from an exercise perspective, 30 minutes of a good cardiovascular type activity where your heart rate is up, you're a little bit out of breath. And ideally, if you could do that 5 times a week, 5 days a week, that's going to go a long way. So that's something, in terms of prevention. I guess coming back to your most recent question is about, okay, well, how do we screen? And, this is where, unfortunately, I think there's a lot of misunderstanding. There's a lot of misinformation, perhaps, if we can call it that, about prostate cancer screening. And the reasons for this are many, perhaps a little bit beyond the scope of this talk, but, has to do with the historical context of how we used to screen, how we used to treat prostate cancer. A lot of the data that's out there, even amongst the medical community, is a little bit misinterpreted, misunderstood. There is definitely, clear evidence about the benefits of prostate cancer screening. The way that we screen is twofold. And I know people don't like it. I don't like to do it. They don't like to have it done, but it's something that needs to be done. It's the rectal examination of the prostate. That's one component. And the other component is the Psa blood test. So this is a blood test that, there's a little box on the requisition form that we can check off. If it's indicated, it'll be covered by OHIP. It's not something they have to pay for. And sometimes if it's being done, outside of the typical context, based on evidence, then, the physician will say, hey, this is a test that you might have to pay for. It costs $35 or something like that. But the vast majority of the time, I think, if a patient's seeing me, for sure, if I'm screening, I feel confident enough in the data that I'll make sure that test is being covered by OHIP. And so, yeah, it's very important to do both of these tests. We've seen countless number of patients where they'll have a cancer that is not as manifest in the PSA blood test, but is very apparent on their rectal exam with a finger. And then we'll have other scenarios where, the cancer is not detectable on the rectal exam, but the PSA is very abnormal, and we pick up patients that way. So it's really sort of a two-pronged approach, the PSA blood test and the rectal exam with a finger. And, when do you start getting these done? So typically we'll say that if you're of an average risk, then you could start at the age of 50. And there's a lot of nuanced guidelines. Some will say you do it every, 1 year, and then based on what you find, you can skip out to 3 years, or some will say you do it every 3 years to start off. There's a lot of nuance. I think the simplified sort of approach is to screen after you turn 50, every 2 to 3 years, you have screening. And if you're of Black race, or if you have a first-degree relative with prostate cancer, then ideally you should be starting at age 40 or 45, according to some of the societies that are out there, the medical and oncology societies. So yeah, generally every 2 to 3 years, PSA and a rectal exam should be good to go.
That's really, really valuable to know. So, I mean, I guess, the jury is not fully out in terms of, knowing, is it just one or the other? But in your expert opinion, it's good for people to know that they can't skip out or shouldn't skip out on one or the other. So if they go to their family doctor and the family doctor gives them a choice, which is fair, they would probably want to, you got a choice, but you probably want to agree and just have both tests to make sure that that screening is being done, as thoroughly as possible. I think that's what I'm hearing you say, and that's what our viewers, all the men, and even if there's women viewing today, that's great, because you can let your husbands, your spouses, your partners know. That's what's key. You got to have both of the tests. Don't cop out, and get it done. So the next thing is, prostate cancer. You said you started off by saying about 1 in 7. You mentioned if someone lives long enough, they say that they may be more and more at risk. These are really real things. What are some of the, I don't want to go too deep into it, but if someone, let's say, hasn't had any tests done, or has had tests done, but it's been a long time, because this is what happens in the general population, could you talk about some, or if any, red flags? We think about red flags, like what are things that we, or people out there should really worry about? I don't know, not eating as much or losing weight. Like, is there things that are associated with it? And it doesn't have to necessarily be prostate cancer, but maybe even other things. But as we're speaking about that, are there things that you advise?
Yeah, definitely. I think red flags, certainly in urology. If you see visible blood in the urine, that's going to be a red flag. Visible blood in the urine, can occur commonly with, let's say, a urinary tract infection or a kidney stone. Usually, those those conditions are going to be associated with some pain. So we get a little bit more antsy, or a little bit more concerned about painless blood in the urine. In other words, they have blood in the urine and there's no pain. It just sort of randomly shows up. I think that should be considered a red flag for further investigations, for sure. And one of the things that you mentioned, yes, in advanced stages of cancer, a worsening appetite, unexplained weight loss, significant weight loss in a short period. These are important sort of red flags to look at. Yeah, I mean, in terms of prostate cancer, just to put it into context, there were studies that were done many years ago which looked at men that died of all causes. And when those men died, they did autopsies on them. They examined their prostate. They found that 80% of men that were above the age of 80% of those men had prostate cancer, and they died with it. So, it certainly can be a condition that is indolent, that sort of can remain silent. And a vast majority of men, when they hit that age, will develop prostate cancer. But when we talk about screening, that's what we're really trying to get at. We're trying to pick up that subset of patients, like that patient that you mentioned, and countless patients that we've seen and treated, that are in their late 40s or early 50s and are developing metastatic prostate cancer. So we have to understand that cancer in general is very heterogeneous. It's very different. Different types of cancer behave differently. But even within prostate cancer, there's going to be, low risk or less aggressive, medium risk, medium aggressiveness, and high risk, high aggressive type cancers. So the screening is really intended to pick up those patients that are going to behave poorly, that are going to have a very aggressive form of cancer. And it's less intended for the indolent type of cancer that we just highlighted with that example that I gave. So the red flags, certainly you should look out for. We talked about, but I think again, just to have that caveat that usually those red flags are going to present in a later stage. So being proactive, right? We talk about the lack of preventative medicine a lot in the medical community, and I think diet, exercise, and early recognition of disease are very important.
Thank you. I don't want to go too deep into what happens, when someone gets this, and all the treatments. I'm sure that's, very advanced stuff. And probably in the short time that we have, I wanted to shift gears just a little bit. And one of the questions that I've received before, from a patient, and I'm just going to put it out there, was, he goes, "Doc, what's the difference between this enlarged prostate, a big ball in the prostate that's cancer, or that's just big?" And I think that's how I'll start off the next topic, because this sort of BPH, and you can explain exactly what it means, and tell people out there as the expert, what are some of the signs and things associated with that? How does it differentiate from cancer, perhaps? And what should people know? Because this is another thing that's quite common that we see, and that I'm sure you treat, and people should know about that. And so I'll stop there, and have you tell us about that.
Yeah, no, excellent. I mean, you hit the nail on the head. I think it's very important to, part and parcel with prostate cancer, recognize and be aware of BPH. So BPH is actually it's a naturally occurring condition that will happen in every man, regardless of your age, your family history. Sorry, every man to some extent will have enlargement of the prostate. That's benign. So BPH is benign prostatic hyperplasia. Benign meaning non-serious, non-cancerous prostate, and then hyperplasia meaning increase in cellular content, increase in size. So BPH happens in all men as we get older. I tell my patients, in some men, the prostate will increase from the size of a walnut up to the size of an apricot. And in some men, the prostate will increase from the size of a walnut all the way up to the size of a grapefruit, and sometimes even larger than that, a small coconut we've seen. So the prostate can enlarge to varying degrees, but every man as he gets older will have enlargement. This has to do with our hormonal milieu, or the balance of hormones in our body. It has to do with family history as well. So if your father or your brothers have had an enlarged prostate, then you're more likely to have one. But to some extent, everybody has enlargement. And the very common conditions that a lot of guys joke about, a lot of men, you see it in media, movies, and TV. As they get older, they're saying, "Yeah, it takes me so long to pee. I can't pee my name in the snow like I used to." Or they'll say, I go and I use the bathroom, at a public forum before COVID, and one or two young guys will come and go, and I'm still in there. So the common symptoms of an enlarging prostate, we have a mnemonic, that we learned in medical school and in urology. It's called WISE FUN. WISE FUN. So weak stream, the flow of urine slows down. Intermittency, sometimes there'll be a little bit of stop and go. Straining to void. So sometimes, you have to take a few seconds for the flow of urine to start, and you even maybe have to push it a little bit. Emptying incomplete. So incomplete emptying is where you feel like you're done. You finish, but you don't feel like you're fully done. You still have, that sensation that something remains behind. So that's WISE. And then FUN, frequency of urination. So sometimes you have to pee more frequently. Typically, we say the normal, well-hydrated person will pass urine every 2 hours or so, 2 to 3 hours throughout the day. And, if you're peeing every 45 minutes or every hour, that's a little bit more frequent. Also urgency, where you feel like you have to rush to the bathroom a little bit more often. You're driving, you have to pull over to Tim Hortons or whatever. And then also nocturia. So nocturia is where you wake up in the middle of the night more often to pee. A lot of the times in the early stages of the condition, patients will find that the symptoms are happening more prominently, like through the night or first thing in the morning. But then as they, advance with the enlargement of the prostate, they'll find that it's also happening throughout all times of the day. So these are the very common symptoms that men will experience as they get older. These symptoms are generally attributable to an enlarging prostate. This is a benign condition. Just to put it, some people, will understand things better when you sort of give them an example. So I give them an example of, like, if you imagine the bladder to be a muscle which holds the urine, and the prostate a donut which sits below the muscle. So when we pass urine, the urine flows through the middle of this donut. And if the donut enlarges, the hole tends to restrict. And so this is why you get all these, slowing of the stream, stop and go stream, feeling like you're not emptying. So this is BPH. Is a very common condition. We have a lot of, good treatments for it. So something to be, aware of. It's not necessarily that these symptoms reflect prostate cancer. The vast majority of these symptoms are going to reflect enlargement of the prostate, which is what I think you were getting at.
That is extremely helpful, especially wise fun. Wise, as you get older, you said that the symptoms, you're more likely to have these symptoms, and fun, well, it isn't much fun. So basically what you're saying is that, most men, let's say even almost all men, if they're approaching 70s, 80s, 60s, but even if they're not that old, they may start to experience some of the symptoms from wise fun. And I guess that always begs the next question. Someone's having, let's say, one of these or two of these, how soon should they be seen for that? And of course, some of these symptoms may overlap other urological, problems, as well as cancers and other things. So how soon should they be seen? Let's say they have 2 or 3 of these symptoms from wise fun, and what do you do about it? Like, how is this treated? What do you do? How do you make, pardon the analogy, but how do you make a chocolate dip that's becoming like a Boston cream? Like the chocolate dip is becoming a Boston cream donut, and how do you stop that from happening? And what do you guys do about it?
Right. So with the enlarging prostate, sorry, the first part of your question was a really good one. Oh, I forget. So anyways, but I think the crux of it is, what do we do about the enlarging prostate? So with an enlarging prostate,
just to tell you, the first part was that, wise fun, if someone's got one symptom or two symptoms, or like, how soon should they be seen, and what do they do? Because men, we all hesitate to go see the doctor. We don't have time for this. We're taking care of our families. We're working. So those are the type of things that would be good for people to know, I think.
Perfect. Yes. Thank you for reiterating that. So yeah, I think one of the things to know, generally these symptoms start at around the age of 50, but certainly we have a subset of patients where we'll see it, starting to happen in the mid to late 40s even. And that tends to be, again, indicative of family history. So, their father will have had an enlarged prostate, and potentially they're having it a little bit sooner. So generally, though, these symptoms will start at the age of 50. At what point should you seek medical attention? It really comes down to the degree of bother, to be honest. When the symptoms become unbearable, like a lot of times men will say, yeah, I wake up once or twice in the night, but I'm able to fall back asleep. And I prefer to avoid, medications or surgery, and carry on. By all means, carry on. So it really comes down to the degree of bother. There's going to be absolute indications for us to intervene. Absolute meaning, where we say, okay, it's mandatory to intervene. For example, a patient that has recurrent urinary infections, a man that gets recurrent urinary infections every few months, he's on antibiotics because he keeps getting infections. That would be one sort of absolute indication. Another absolute indication would be recurrent bouts of retention. Retention is where, the situation gets so bad. Sometimes it gets so bad where you want to pass urine and you can't. You can imagine how, devastating and how, difficult of a situation that could be. They end up in the emergency department. A catheter, a tube has to be put in to help the urine come out. So if this has happened, on one or more than one occasions, then that's another sort of point at which we say, okay, we definitely need to consider treating this. And then the third would be something that would have to be tested for, but this is where a patient has a very elevated residual. In other words, normally when a young man passes urine, the bladder empties, there is zero residual. But as men get older, the prostate is getting larger, that middle of that donut is getting tighter. And because the bladder doesn't empty fully, there's going to be some residual urine. If the residual starts to become, 200, 300, 400 milliliters, that's another point at which we have to intervene. It's normal for a man, in his 60s or 70s to have 30 or 40, 50 milliliters left behind. But basically, those are the three things: recurring infections, ending up in retention, which, is something very manifest and obvious. And then the third one is more maybe, your family doctor does an ultrasound or something and they find out that, hey, this patient's bladder is not emptying, as it should. So those are the points at which we have to intervene. In terms of the intervention, I guess that's something that you had mentioned as well. So what do we do? If the patients are sort of in a situation where they say, you know what, I was just concerned about these symptoms. I just wanted to, check in and know about what might be going on. A lot of men will say it's manageable now. It's tolerable for me. I'm glad to know that it's nothing serious. I can carry on. And so we say, carry on. Some men will say, this is really affecting my quality of life, and I'm interested in having some treatment. And so generally the first place we'll start is medications. Medications we'll use one common class of medications called the alpha blockers. These are medications that help to relax that donut, open up the prostate a little bit so the urine can flow better. And generally we use these because they have less side effects as compared to some of the other medications. They tend to work fast within days. Unfortunately, these medications are intended to be taken indefinitely, kind of like a blood pressure or cholesterol pill. You'd have to take it indefinitely. As soon as you would stop using the medications, your symptoms will go back to what they were originally. So, that's the one downside, but that's one group of medications, alpha blockers. A second group of medications we'll use is what's called 5-alpha reductase inhibitors. These are medications that are intended to shrink the prostate. And by shrinking the prostate, again, we're opening up the donut a little bit so the urine can flow better. Again, this is a medication that has to be taken indefinitely. It takes a little bit longer to work. Typically, we're looking in the order of months before we have the maximum effect. And they tend to have more side effects. So I really sort of am reluctant to use that in younger men, especially men that are still sexually active, because it does, affect that. So, and we know, a lot of patients intuitively ask for this drug. They say, well, I want the drug that's going to shrink my prostate. And I think what's important to recognize is that, this is not sort of a 0, to 100 type situation. The medication is maybe going to shrink the prostate by 5 to 10%. So it doesn't make a very dramatic difference in the long term, but it certainly can help, appropriately selected patients in terms of trying to alleviate some of their symptoms. I'm a surgeon. I'm a little bit biased, but I truly and honestly believe that surgery is a very good option, for enlarging prostates. There's various types of surgeries that, if you want, we can get into, but the underlying principle is to basically pass a camera, through the penile opening and then to core out or hollow out the inside of that donut. And by opening that up, we're allowing the urine to flow unimpeded. You have better emptying of the bladder. And the reason why I'm sort of more in favor of surgery is because it's sort of a one-time fix. You don't have to be on medications, indefinitely. The other thing is that the surgery tends to produce a much more robust opening. The prostate will be open to a much more improved degree. And then the third thing is the surgery generally tends to last a good, depending on which one you do, in the order of years. Some of the surgeries that are out there are going to be, a 5 to 10 year longevity, and some of them are going to be 10 to 15 year, 20 year longevity. So surgery is an option as well to open up the channel. So all of these are, available.
No, thank you. Thank you for sharing that. What stuck out to me from what you mentioned was this is something for all the men that are viewing right now today, as well as that view in the future or that you talk to. This is something that, should be in the back of a lot of men's mind, because we're all going to face this at some point. And to know the symptoms, the signs, from what you're saying in your expert opinion, how treatable this is, why 2 different medications, which are safe, I'm guessing, because or else you wouldn't give them to people. Surgery, which can take care of this for in and around 10 years, 15 years, a long time. These are things that are treatable. And we all have to kind of worry about it, or keep in the back of our head as we age, inshallah, and get older and older. And we want to make sure that we don't neglect these things. And I think that's what this is all about. Like, we seek help early. We're not just running around, dancing around, when we have to go to the bathroom, or maybe not able to go when we finally get there. And some of the things you mentioned about why it's fun.
Sorry,
What? Yeah.
Sorry to interrupt. So sorry. But one other thing I think is important to
Sure.
mention as well, because we often get asked about this, is sort of natural remedies, natural supplements for the enlarging prostate. Maybe you were going there anyways, but yeah.
I was
So
going to ask you about that.
yes. So we call these phytotherapies. Phytotherapies are sort of various supplements that have been, documented or have been perpetuated in the medical and non-medical communities that could help with an enlarging prostate. There's a lot of stuff out there. Pumpkin seed extract. The main one is saw palmetto extract. So this is from a berry, the saw palmetto berry. Pumpkin seed extract, bee pollen extract. They talk about lycopene from tomatoes, and so there's a lot of stuff that's out there, selenium, etc. A lot of these natural supplements were actually studied probably 2-3 decades ago, and initially out of all of them, the one that showed the most promise was saw palmetto. And so saw palmetto is a natural phytotherapy that in most of the prostate supplements that you'll see, you go to Walmart, Costco, or you go to the GNC, you'll see prostate medicine, prostate vitamins, super prostate. So a lot of these, the main ingredient is saw palmetto. Further, more sort of robust studies were done, which showed that there was no clear advantage or benefit to these medications. So we don't have a lot of strong evidence from the literature. However, there's a lot of anecdotal evidence. We see a lot of patients that will come in and say, "Hey, doc, before I came here, I started taking this and it's helped me." So we tell the patients this: look, there's no clear, strong evidence for these things to work, but there's no downside either to taking them other than the cost. So if you're okay with the cost, try it. If it works for you, great. And if it doesn't work for you, then you don't have to take it. So that's sort of the approach we take with those phytotherapies. And I think the other important aspect to mention is that the degree of enlargement, like I said, will vary, and so the symptoms will vary as well. So some men, their whole life might not need any treatment, and some men will need treatment earlier. So just to recognize that it will affect everybody, but maybe not to the same extent.
No, that's great to know. I'm glad you touched on natural remedies, because it's one of those things that these days people have on their mind. They don't want to take medications right off the bat. They want to explore other options. They want to educate themselves. They want to talk to people. They want to see their naturopath. And there isn't actually anything wrong with that. It's just that what you're saying is based on the robust studies and evidence. There isn't something clear that says that this will make the problem go away. I guess that's what readers, and will sustainably help the issue. But like you said, it won't hurt. And if people are open to that and want to explore that, of course, they can reach out, to their family doctors and their specialists who they see. I think another thing that stood out to me when you were talking about just the treatments was, that second treatment you mentioned, the 5-alpha reductase or something like this. It doesn't really matter to people whatever that was. You mentioned that to younger patients, and young is relative term. I think 50, 60-year-olds are pretty young. But to younger patients, it may cause some sexual side effects and other things, and you're a little bit hesitant to prescribe that, which rightfully so. I guess I want to use that to lead into our final topic for today, as we approach the close to 40-minute mark of our talk, and time is just flying by today. But I want to just take a couple of minutes to address something, with your permission, that is so common. I'm not saying that as a family doctor, but I'm just sharing that because people don't talk about it. I think especially people in our culture, don't talk about it, but men in general don't talk about it because it is a part of your, let's say, manlyhood. But in the next topic I want to bring up, when you brought up sexual issues, is ED, which is better known as erectile dysfunction.
Mm-hmm.
And This is a real thing. This is a real thing. I'm not an expert. The little knowledge that I have, it's not uncommon. It could also be quite common, but it's just not something that people are going to talk about in the locker room, after a game of ball hockey, while they're watching UFC with their boys or watching Super Bowl or whatever they're doing. It's just not going to, and they're likely not going to talk about it with their spouse, with their partners. And so I want you to, I know it's not a big topic, but I want you to address what you think the key takeaways and important things that people in the community, in our community, really should know about erectile dysfunction. How common is it? When does it show up? Can a 30, 40-year-old have it? What can they do about it? And how soon? What are the symptoms and signs? Some of the same things. The floor is yours with that, and I'll definitely prompt you. But as an expert, share your wisdom with us about erectile dysfunction, Dr. Sheikh.
Yeah, definitely. Huge topic in terms of the I guess lack of discussion and the taboo sort of nature of the topic. I think it also ties in a lot with men's mental health. This is something that we as men, we're a little bit reluctant to sort of disclose our, emotional status, and something as intimate as this, can be thought of similarly. So it's definitely something that's very prominent and prevalent, and definitely something that we need to talk about. Erectile dysfunction, we see it in all ages. Generally, yes, the prevalence, of course, is going to increase with age as our body ages. Our blood vessels age, our nerves age, the physiologic sort of components of having an erection, those are affected as we get older. But certainly, we'll see men that are, in their older years that are still functioning, and we'll see men in their younger years that are not. So, what are the things that affect erectile dysfunction? So it's a big topic, but I think we can sort of compartmentalize it into a smaller topic. Basically, with erectile dysfunction, the vast majority of these are going to be multifactorial. There's going to be many small things coming together that will contribute to erectile dysfunction. I think understanding the causes is going to be important to be able to understand, how best to address it preventatively and, after it's occurred. So the multifactorial nature of it, we can break all of these different factors into three categories. We call them the three categories. One is the organic factors. So the organic factors has to do with physical, biological sort of elements that affect our erections. Basically, the nerve supply to the penis, the blood supply into the penis, the hormonal state, etc. So things like high blood pressure, high cholesterol, diabetes, heart disease, obesity, being overweight, previous surgery in the pelvis, previous radiation treatments to the pelvis. These are all sort of the organic factors that are going to affect erections negatively. So that's a big one. The second category is what we call the pharmacologic factors. So this has to do with certain drugs. Anti-hypertensive blood pressure pills will have a negative effect on erections, but it's very important to be taking your blood pressure pills because there's a cardiovascular risk there if you don't. So blood pressure pills, anxiety medications, antidepressants, narcotic painkillers, blood thinners, and then even non-prescription drugs, non-Muslims that drink alcohol, smoking cigarettes, marijuana, recreational drugs. And then the third category is what we call the psychogenic factors. And this is a big one. A lot of patients will sort of brush this off or tend to try to avoid, even discussing this. And this is more prevalent in the younger people. We'll see strapping, healthy 30, 25-year-old guys coming into our office saying, I got erectile dysfunction. And when you dig deeper, there's a lot of things that can contribute to that. Patients that have had, a recent divorce, or patients that are, there's a lot in our community. We see this a lot where families are pressuring, newlyweds to have children. And so they're really, trying to time intercourse and make sure that, they're on top of the ovulation schedule of their wife to try to get, a child. So that's a big one. Or, just financial issues, work-related stress, family-related stress. all of these stressors will have a big impact on erections, and it's something that a lot of the times people will say, well, no, I don't have any of that, right? Or it doesn't affect me. I have it, but it doesn't affect me. A lot of this is playing at a sort of a subconscious level. And it's sort of a vicious effect where, you have one or two bad, performances, let's call them. And then after that, it starts to play on the mind. Oh man, last time it didn't work out. Is my wife or my spouse going to be, dissatisfied? And these things sort of compound. So that psychogenic element is something that's very real and very important to recognize. So again, these are the three categories: organic factors, pharmacologic factors, and psychogenic factors. So how do we avoid erectile dysfunction? How do we address erectile dysfunction? Is by, working on these different potential components. So again, we go back to diet and exercise, right? One of my professors used to say this. He used to say that the penis is the barometer of the heart. So I know that sounds a little bit lewd, but yeah, basically what he's saying is, if the erections are in good order, then you know that your cardiovascular state is good. And, it's really rung home because I've had a few patients that had come to see me and, with this problem, erectile dysfunction, 40, 50-year-old guy, 35-year-old guy in one case. And a couple of years later, they came back to see me for the same or another issue. And it turns out that maybe a year or two after they saw me, they ended up having a heart attack, a cardiac event. And this always, whenever I saw that, the hairs on the back of my neck sort of rose because what he said was so true. The penis is the barometer of the heart. So really focusing on good cardiovascular health, having regular exercise, these things make a big difference in the long run. Avoiding high blood pressure, avoiding diabetes, avoiding high cholesterol. So that's what we can do in terms of prevention, quit smoking, et cetera, managing stress. And then in terms of treatment, the treatment sort of, there's pretty straightforward. It's like first line, second line, third line. The first line treatments, there's medications that I'm sure a lot of people are aware of, Viagra, Cialis, Levitra. The second line is going to be potentially penile injections. There's also penile vacuum pumps that can be used. A little bit intricate in terms of how to explain how they work, but we can get into that if needed. And then the third is sort of a more dramatic measure, which is going to be a penile prosthesis. So they actually do surgery where they will insert a prosthetic device to help facilitate erections. So that's really a last stage resort. And we don't use that obviously in very young men, but just to be aware of those three sort of tiers of treatment. The best being prevention, right? As in a lot of other medical conditions, prevention is the best for this as well.
That was extremely valuable. To me, one thing that stood out from what you said is bringing together almost like a theme. We started off with prostate cancer. We ended with erectile dysfunction. And one of the themes, as you just finished mentioning, prevention is diet and exercise. And it's so interesting, right? Because we talk about it, we know that, but we don't think that men's health, specifically cancer, erectile dysfunction, these are big things. Maybe even, that BPH stuff you talked about and others that we haven't even had time to get into today are really affected by these core things like diet and exercise. I mean, we all love to have huge unhealthy meals. I certainly do. But keeping in mind how important exercise, diet is, maintaining a good lifestyle. I'm glad to hear that there are things that people can do, quite easily, I would say, or make a New Year's resolution that comes up in another month or so, or start today. And there are things that they can do to help with some of these things that are real problems. So thank you for sharing that. So that's the common theme that that you put together. I will just share one interesting fact. I remember during my training a long time ago, this is probably going back about 10 years ago, a patient came to me and he asked for, "Hey doc, I'm just here to get a quick," and I was in my training at the time during medical school, and he said, "Oh, can I just get a blue pill?" And I honestly had no idea what that was. And he repeated himself a couple of times. And my preceptor at the time, my supervisor, was a female. So he actually felt very comfortable just coming in. He was in a rush, middle-aged man. He said, "I want the blue pill." And I really didn't know what that was. And he started laughing and he said the word Viagra. or or Cialis, and so that's just something wanted to put out there for the viewers and the audience. Like if it's a little embarrassing to ask for that or even get on that topic, there's ways to bring it up with doctors, and there's things that people mention, and it's not a bad, we all have a difficult time getting into these things. How do we talk about it? But some of the things you hit on today were so valuable that these are not things that people should neglect. Their mental health, the organic causes of sure investigated, and then of course the pharmacological things you mentioned by drugs, and then of course the psychogenic or mental health. Such a big thing, right? And I'm glad you shared those things. You brought it out in the open. You educated members of our community. Certainly, this won't be our last session with you, because I think this is a huge topic, not just ED, but men's health. And there's a lot of value that you can add. I guess I wanted to leave with this. We're at about 50 minutes, maybe just over time. But before I wrap up and summarize, I wanted to get your final words. What do you have to tell our viewers and our audience today? It doesn't have to be related to what we spoke about, but just words of wisdom coming from you would be very valuable to us.
No, first of all, I think this forum, what you guys are doing, Jazakallahu khair for this. I think this is a great starting point. It's just to be able to talk about these things, to be raise awareness about these things, and that's maybe something that can be amplified, right? People that have attended today, when you're in your circles in the future, bring up these topics, talk about these topics, have people aware of them, try to break the stigma, and if there's anything, that I hope people take home from this is really the preventative strategies, so diet, exercise, just in so many, in terms of mental well-being, in terms of your, physical conditions, cancer prevention, the list goes on and on. So I think that's probably the two things, break the stigma and preventative measures.
Thank you, Dr. Sheikh. I'll just add a quick one on my own. I think the main thing is that what sometimes I think to myself, and I think you pretty much alluded to this, is, break the stigma. What advice would you give your father, your brother, your best friend if they shared this with you over, a coffee at Tim's, or, while you guys are just, maybe just hanging out, chatting, talking about something? If they brought this up to you in confidence and they were really struggling, what advice would you give them? And probably to seek help, to bring it up, to talk to others about it, and to raise awareness about it, and get the help that they need. Your time today, and our privilege to have you as part of this community health series, kind of sponsored or pretty much run and hosted by the Muslim Medical Association of Canada. It means the world to us. You're a valued member, not only as a physician, but a valued member of our community. I know how much you're giving back to the community. Just being here today for this hour is not a full testament of what you've done for our community. So I wanted to sincerely thank Dr. Sheikh for being here today. It certainly won't be the last time that you're here with us. I wanted to also thank our viewers for being here today, for supporting this community health series. This isn't the last time you can view this. Please share this link. I recommend for everyone to please subscribe to our Facebook, to our Instagram, Twitter, YouTube pages at Muslim Meds, and view these recordings. There will be more episodes that will be about all sorts of different topics. Share it with your family and friends. I think this is a gift that we have learned people like Dr. Sheikh in our community that are willing to give back. And thank you so much. So with that, I wanted to end there. Thank you to our viewers. Thank you to the people in the back, Tibian and others that have been there making sure that things run smoothly on the technical side, of course, and the whole entire community health series team. We have many physicians and other members that put these together. So thank you once again, and we'll end there. Jazakallah. Assalamu alaikum. Assalamu alaikum.
Wa alaikum salam. My honor. Thank you so much.